Thank you. Mr. Chairman, colleagues, here we are again. It's about 5:15. I think it's the 24th hour of lectures we are listening today. So I encourage you to resist these 20 minutes. It will not be easy. Anyhow. Comorbidities, management of the disease. Heart failure is a final common way of every heart disease, so it's obvious that any disease can be associated. We have been used to consider anemia, diabetes, hypertension, kidney dysfunction, stroke as usually associated, usually the most common comorbidities. In the recent years, in the very recent years, also any cerebral disease, including depression, has been associated as an important comorbidity. And please forgive me, but you know, cardiologists are simple people. COPD has appeared in the talks among cardiologists much later than it was among pneumologists, and this is rather interesting to understand. Anyhow, COPD is now considered an important comorbidity in congestive heart failure, also in the talks among cardiologists. Interesting, different series have a huge range of prevalence. Whatever is the comorbidity, the interesting thing is that the presence of a comorbidity is associated with a bad prognosis associated to heart failure. And this is interesting to think about, to work about. So why the concept of comorbidity is important when working and when dealing with heart failure? Well, because a comorbidity may affect the use of a treatment for heart failure. And the usual example is the use of an ACE inhibitor, for instance, in some patients with renal dysfunction. Secondly, drugs used to treat comorbidities may cause worsening of heart failure. We sometimes face the issue of the enormous problem of older people assuming non-steroidal anti-inflammatory drugs and appearance of a phase of unstable condition of left ventricular function. Then, third but not least, drugs used to treat heart failure and those used to treat comorbidity may also interact one another. And the usual example is, again, beta blockers and beta agonists. Interesting thing, in Italy, not more than 10% of subjects with known COPD assuming a beta agonist with known presence of heart failure are also on beta blockers, and the other way around. This is rather interesting as a behavior. I can make a very long introduction very short. This morning we had a beautiful talk by Professor Krein, so this concept has already been covered, but I just want to say again this word, cardiopulmonary continuum. Heart and lung are in the thorax, quite close and probably related. This obvious concept is not transferred very easily in the common practice. This is from the current heart failure guidelines by European Society of Cardiologists. I have to blame myself because my name is also on this publication. This is all is included about COPD. That is to say that when a specialist is dealing with his own field, very seldom is concentrating on what is happening around, and is going with evidences, and the evidence are usually associated with the disease, not with the comorbid condition. And this is, again, a very important concept. Well, what is mentioned in the current guidelines, and the next one are going to appear are not covering widely this field, are these very obvious sentences, which that I do not even repeat. But the important thing is that no evidence-based recommendation is given. So there is no recommendation for the cardiologist about the possibility of treatment, of management of a patient with COPD as a comorbidity. And this is, by all means, a nonsense, because we know that in patients with COPD, the risk of developing heart failure is 450% higher. And this is absolutely no minutes. And FEV1 is a good predictor of cardiovascular mortality, as it is cholesterol. Interesting thing. It is 10 years that the concept of comorbid state is common also among cardiologists. This is the first important publication on the issue. The interesting thing, well, this is the concept that called the attention of the cardiologist in about 20% of COPD patients, symptomatic left ventricular dysfunction was present. This was quite striking at that time. The interesting thing to me is that this publication has been done by a general practitioner, not by a pneumologist, not by a cardiologist, but by a general practitioner. And this is, again, very interesting to understand the issues. There are very many series of patients evaluating, usually retrospectively, sometimes prospectively, the association of the comorbid state. I don't go into details, but I choose this publication just to call your attention that if it is obvious that comorbid state makes the prognosis less good, it is also true that it is not being a constant in literature. There are two cases where the association, well, let's say the size effect is quite small. There are 3 cases where this association was not demonstrated. I call your attention on a paper by our group. First name, Dr. Boschetto. She's sitting here in the audience. And I have to say that this study has been done thanks to her determination and her continuous dedication to this work. Just a few words on what I'm talking about. I will please remind this few data because I will call back to this population a couple of times during my presentation. It may seem that 118 patients is not a great number, but it is a great number. It is a series of consecutive, 118 patients consecutive, all of them with more than 65 years of ages, with an history of smoking, and with the new diagnosis of congestive heart failure. That is to say, incident cases of heart failure, completely new to heart failure clinic or cardiological departments. And in this case, 120, it becomes an interesting number. What did Piera demonstrated? Well, that 30% of patients had comorbid state, demonstrated by measurement, not clinical diagnosis, but by instrumentally. And if you think that 30% of patients, well, I'm sure you don't think that 30% of patients is a small number, but consider that these were patients admitted for heart failure, and all but 2 were not aware of the pulmonary conditions, so they did not know about. And the measurement was not communicated to the cardiologists that were taking care of the patients. Just a second to call your attention that I think I've learned that this can be considered a condition not very advanced, GOLD1 and and gold to the large majority of patients. These are simple Kaplan-Meier curves in 118 patients. Over a period of observation of 2 years, the difference was not significant. The size effect is also small, so it's not only a matter of numbers. But our conclusion was that it is likely that in the less advanced gold stages, the impact of comorbidity on prognosis is not dramatic. And this may appear logical if I've been able to explain the data. And because of this reason, that the comorbid state will stay with the patient for a long period, a tailored and optimized treatment is probably a key aspect. And it is also likely that, that a major heterogeneity of phenotypes exists in our patients, and we are missing mechanistic insights and any information of the interplay between the two diseases for the progression of the prevalent clinical disease. Let's move on. I've been given a title. In the second part of my presentation, I will try to explain these three possible perspectives on the critical issue of therapeutical management of patients with heart failure and comorbid state. Well, first question is if having COPD will influence the choice of therapy for heart failure, obvious. If taking a treatment for his COPD modify the outcome in chronic heart failure, less obvious. And does take a treatment for heart failure affect COPD? Even less obvious. Well, the first one is a very obvious question. I could have shown tens of examples for literature. I choose this one because it's a general population and with some numbers. And as you can see, 1 out of 3 patients that are eligible for beta blocker therapy for heart failure are not given a beta blocker because of COPD. So the common belief in the general, among doctors is that this is quite a recent, well, 10 years ago, but also very recent papers are along this line. Nowadays in Italy, just 80% of eligible patients for beta blockers are treated with beta blockers, and in this 20% of paper, about half of these patients are not treated because of known pulmonary disease. And this is, again, if you consider that bradycardia or hypotension are very rarely a cause for not treating the patient, this is even more interesting. Luckily, Professor Selly is not here anymore because I'm showing the very known meta-analysis by Cochrane Institute that measures that FEV1 is not influenced by a selective beta blocker. I will not waste your time on this. What about our patient? Well, 118, I repeat again, but the physician was not aware about the result of spirometry of gas and gas exchanges. Well, the association of COPD did not prevent the up titration of the beta blocker, nor the number of patients that were up titrated up to the maximum dosage of the beta blocker. And in these patients, not only selective beta blockers were used, but also carvedilol. That was actually the most used one. That is to say, if a physician is not aware of the comorbid state, is not influenced by but any clinical outcome, and the maximum dosage of beta blockers can be reached. So does taking treatment for COPD modify the outcome of heart failure? I know that I will show you something in a way provocative, but understand me, I am a cardiologist, and I face the numbers and the the drugs you use commonly. This is not a recent meta-analysis, but also recent data on the use of beta agonists show that also the topic administration of compounds is sometimes associated with problem with the management of patients. And we can discuss, you can tell me very clearly that this a problem of the dosage and selection of patients and so on. But if I go also on vagolytic agents, I find in literature many papers that show that suggest an adverse, an association between anticholinergic and adverse cardiovascular outcomes, as well as I find patients suggesting, studies suggesting just the opposite. So which is the, well, I could ask which is the correct position, the correct, I thought it was clear when the uplift was published and where it was demonstrated, where it was measured that cardiac outcomes were actually decreased by the treatment. Is this enough? This is a paper dated 2 years ago. This is not a study. These are big data. All individuals aged 65 or more with COPD in Ontario State between these 5-6 years have been enrolled. This is not a sample. These are big data. All the population. I will not go into LAS, LABAS, and I don't understand this kind of animals, but these are the results. And to make the a very long story short, the conclusion was that among all the individuals with this COPD, new use of a long-acting agonist and anticholinergics is associated with similar increased risk of cardiovascular events. This can be by a lot of different aspects. Can be a side effect, can be an adverse effect, can be the fact that giving chronic therapy with LABAS, I don't know, we are selecting the more advanced stage of the disease. So this is obvious. But this is also clear, and it is well summarized by the authors, that a close monitoring of COPD patients requiring these drugs is needed. And in this case, today it has been very interesting for me to see the pneumologist's point of view, the indication by pneumology of coronary angio and so on. My point of view, my humble point of view, is that our interaction should be in this aspect, not in very sophisticated and sometimes with questionable benefit-risk ratio. We should concentrate not on the clinical aspects of our patient before going into sophisticated techniques. Let me further add, it is a little bit difficult, roflumilast, is it correct? These are data from internet because the data are quite a few. These, I think, are the pivotal studies for the registration, for the marketing authorization of this compound, and are pooled studies to this end. And it shows a clear aspect that has also been repeated. Treated patients lose weight. It seems that is mostly adipose tissue and not lean mass loss. But this is an interesting marker for a cardiologist because for the patients with chronic heart failure, the single most important predictive factor is the weight loss. Unwanted and unmotivated weight loss over 6 months is the most powerful negative predictive factor. So anytime we are told that there is a weight loss because of anything is a kind of proxy of some problem for cardiologists. Nobody knows if this association is true or false. But even adipose tissue mass is associated with a better prognosis for heart failure patients. Finally, this is again from Piera's patients. 118, but we have been able to measure a difference in oxygen saturation between these two groups. COPD patients had a lower oxygen saturation, and this was associated with a higher level of BNP and a decreased functional capacity. These differences are not peanuts. This is a lot. If I ask to any cardiologist, and I think to any pneumologist, if treatment of these patients for COPD improves functional capacity or prognosis, nobody is able to answer. No data are available. Therefore, I have a little bit changed the sentence. Does taking any treatment for comorbidity modify the outcome in the principal morbidity? Finally, does taking a treatment for heart failure affect COPD? I don't want to be unfair. Professor Cazzola wrote an editorial for this study. It is mentioned quite oftenly among pneumologists, and I've seen a citation of this paper also recently on the Blue Journal. I got familiar with these journals now. And it suggests that pre-treatment with a beta blocker is protective in COPD patients undergoing vascular surgery. Well, I have to say, and I take the opportunity to tell anybody that the institute where these colleagues are working and where part of this data have been produced have withdrawn the affiliation because the studies are subjected to evaluation for possible misconduct. It is 6 years that this process is ongoing. The institute is the Thorax Center in Rotterdam, so I'm not speaking about, I don't know, Gusago, where I have been living for a few years. Not because of the center, because of the small village. It has been a little bit, I didn't. So let's say Desenzano del Garda, but is the most important cardiovascular thorax medicine in Europe. It is not finished yet, the review. European Society of Cardiology have done a new edition of perioperative management of patients in order not to include all the data produced from this institute. I don't know how it will finish, but this is also an opportunity to call the attention on important aspects. Also because the concept of beta blockers is an interesting one. Professor Kreiner already showed these results today, and there is a huge literature with retrospective studies in the very same direction. There are also a lot of studies on statins and ACE inhibition that is in some way associated with the better prognosis for COPD-related events. Is this true? Is this false? Well, this is very interesting. This is the case of statins, and I call the attention on the statins because it is the only example where not only retrospective data are available, but also there is a prospective study. After the seminal paper by Mancini a few years ago, a lot of retrospective studies has appeared, and also a prospective study. What is it? Elkstrom. 2,250 patients, prospective, no significant reduction in mortality. But I'm saying the patients enrolled were on long-term oxygen therapy. I mean, population enrolled was so advanced that prevention, in my humble opinion, is a difficult concept. Maybe we have lost an opportunity, and I think it's important. Then a pathophysiological concept is investigated more deeply in this case because statins have changed. This is my last data slide with data is a meta-analysis to try to say that the whole scenario is even more complicated. COPD patients admitted for acute recurrency. There is nearly all the studies, including our one, have shown that some of these patients have increased level of a cardio-specific troponin. Probably this is also related with a less favorable prognosis from the pneumological point of view. Nobody knows about cardiological point of view. And nobody is able to say where, because this cardio-specific troponin is measurable in the blood, certainly coronary events is not all about. Probably hypoxia is playing a role. Certainly right ventricular overload is playing a role. But this is to say that, well, there is a huge amount of pathophysiology we still have to understand about the association of these two comorbid states. So to finish, the disability burden of the comorbidity is underestimated. This is obvious. It is the whole day I'm talking about. But I couldn't change the slide, Leo. So we have no evidence-based information on the efficacy and on safety of the respective treatments. It would be great to have some mechanistic research. And to finish with something difficult, I think that this sentence well applies to this field. Thank you very much.
Thank you very much. The talk is open for discussion. Professor Fabbri.
Claudio, it's amazing the lack of data. Basically, you know, if you review, we don't have any randomized clinical trial in patients with entry criteria of COPD and heart failure. Am I right?
You are right.
You're right. Now I'm asking, I'm turning to you, Jürgen, because I'd like to ask you whether in the summit study you could separate those who were on optimal cardiovascular treatment and those who were not, and particularly whether you could separate the heart failure from the other at risk or with other cardiac diseases.
Yes, thank you very much. We haven't looked at it in detail. Very briefly, the summit trial was a trial where patients with moderate COPD and some cardiovascular disease were included and received 4 different treatments: placebo, a long-acting beta agonist, an inhaled steroid, or the combination of the two. And the primary outcome was mortality, and there was no significant effect of the drug on mortality in these. Now, cardiovascular mortality was described as either being above 60 and having 2 risk factors such as hyperlipidemia or diabetes, or it was an established cardiovascular disease in those below 60 of age. And we have tried to split it, but of course then we lose power, basically. What we did see was that, first of all, patients got a lot of cardiovascular treatments. We had 2 cardiologists in our steering committee, and they were it was like many other cardiovascular trials that patients were more or less on good cardiovascular treatments, whereas actually their COPD was treated miserably when they came in. The interesting thing was that actually 8,000 people got a long-acting beta agonist and 8,000 did not. And there was absolutely no difference between adverse cardiovascular outcomes in the 2 groups. So I think we can at least say we haven't looked at specifically if there are subgroups where there could be a risk, but the overall point was that there was no effect. And the funny thing was that in the steering committee, the pulmonologists thought this was very sad because it was a negative trial, and the cardiologists thought it was very, very interesting because they would have put all their money that the long-acting beta agonist would kill people, and it didn't. So it's this strange mix. So I think actually that we do have some data now on safety, yes, which I think is comforting.
Any other questions?
Yeah, no, I have a follow-up question, and it's a message and the question, I mean, for the young people in the room is just a message that there is still bad need for clinical research. And in these 2 days, particularly today, every place we put the finger on, we found that we have no data. I mean, and now I come to the question. I mean, and the question is, most of your studies on heart failure are powered on long-term outcomes, you know, recurrence or exacerbations, or not on symptoms. And now we tend to do the same, but we always measure symptoms. The question is to you, what about this treatment on daily symptoms? Are they also very effective? And the ideal trial, I would think, in a patient with both COPD and heart failure would be to optimize both and to see whether they feel better. You know, the dyspnea goes out. They prolong the 6-minute walking distance or something like that.
Leo, as I told also this morning, this is key and very important. Nobody knows, and you know, we tried to implement a study on treatment of COPD in heart failure patients, and we didn't have the opportunity and so on. So nobody can say about that. I can tell you the beta blocker, for instance, that changes dramatically the prognosis, does not improve functional capacity. The majority of our treatments act on prognosis, not on quality of life. I told this morning, the cardiovascular working party in EMA is now ready to release an advice that a compound can be evaluated for marketing, for the license, also on the grounds of quality of life, functional capacity, provided that there is no signal, no bad signal for prognosis. We are in front of a change of attitude. I'm very happy Professor Westbo told that the fact that a topic beta agonist, well administered, can be negative is a conviction that is not true.
Any question? May I comment? There is a very nice paper published on British Journal of Pharmacology by my wife's group in Napoli, linked to Tor Vergata. It's an animal study in which they combined indacaterol and beta blockers. And they were able to document an improvement in lung and heart function. You can look at this paper.
I will.
Gabriella could comment it. But in any case, I think that it's extremely important to look at which kind of beta blocker you are prescribing to your patients. If a normal if you want beta 1 selective beta blocker, but I think that it's more important to look at the inverse agonist. If you use an inverse agonist, you have also an anti-inflammatory effect that is extremely important, that is extremely useful for COPD patients. In fact, probably you have seen the paper that we have published on heart failure and COPD, and we are strongly convinced that you must combine a beta blocker with a bronchodilator, mainly beta agonist, but also antimuscarinic agent.
This is very interesting. Very short comments. I have been told, but please correct me, that in the northern countries, to be a patient with a known diagnosis of COPD to be treated in the public for the health system has to receive a treatment. It would be very interesting to compare if the two treatments, beta blocker and beta agonist, in the northern country, in the northern cohort, have a different behavior respect to the southern cohort, because Spain and Italy do not have this attitude. Final comment, if I may, to the paper on protective effect of beta blocker in vascular surgery, Professor Cazzola finished his editorial with a word of caution in taking for through that issue, and also stressed the aspect of selectivity. So the accompanying editorial was very well balanced.
Thank you.